like to thank Dr. Dogra to give me an opportunity to be a part of his course. I'd like to share with you a few slides with specific stress on certain pearls, as the topic of this instruction course is on the management of retinal detachments with coloboma of the choroid. It's not that the management of coloboma of choroid or retinal detachments is significantly different from a detachment from rest of any other eye, but what is important is to understand what is causing the detachment so that you can manage it appropriately. So the most important contribution has been an article by Dr. Schubert, which has described for the first time what is visible to us is a break in the normal retina or a break in the intracalary membrane, but what we fail to see is a break in the communication between the subretinal space and the sub-ICM space. So the retina is here, normal retina, intracalary membrane is here within the area of the coloboma. So the communication between the subretinal space and the sub-ICM space is not always evident, but that is what triggers the coloboma related detachments, and that has been beautifully shown in this histopathological study, where he has shown that the retina near the margin of coloboma actually splits into two layers. The inner layers, that means the vitreoid layers, continue on as the intercalary membrane, which is a nondescript fibrotic membrane, and which is what covers the colobomatous area, while the outer layers don't just stop short and just get attached to the coloboma margin, they actually turn backwards, and these are water containing photoreceptor layers. So there is a short area where there are actually double layering of photoreceptor layers, and this merges with the retinal pigment epithelium. So that junction is what he called as a site of least resistance, or locus minoris resistentiae. So this is where there must be a break for the subretinal space to communicate with the sub-ICM space, and that's what triggers the onset of detachments. Now this is a study which we published in 1995, where we described the breaks in the intracalary membrane. In fact, if you read this article, I did not use the word breaks in intracalary membrane in the article itself. I call them as retinal breaks in the coloboma for want of a better term. Perhaps the better term actually is breaks in the intracalary membrane. And what we found was breaks like this: large oval breaks within the intracalary membrane, or multiple breaks. You can see here there are 3 breaks outlined by the black arrows, or more often what we saw was where the detachment is like this and spilling over into the coloboma margin in this quadrant. Right at this margin you will find a break which is slit like, where the margin of the break which is towards the normal retina is lifted up, but the margin which is away towards the coloboma is actually merging with the coloboma floor, so it's not visible. So it's not like a full oval break, but it is like a break with half an oval area which is cut off, and that is contributing to the detachment of retina. Now it's not easy to appreciate the small rim of intracalary membrane detachment in all eyes that you see, like microphthalmic eyes with severe nystagmus. It may not be easy. So it may not be easy to detect the presence of intracalary membrane detachment in all the eyes preoperatively. Now let us consider the variables in the detachment. You can have a break in the normal peripheral retina, you can have a break in the intracalary membrane, and you can have a break at the locus minoris resistentiae, which is not clinically appreciable. Okay, these two are clinically appreciable, this very easily and this with some difficulty. If you have only a peripheral retinal break, what do you expect? You expect the detached retina to involve only the normal retina, and it stops abruptly at the coloboma margin. There is no intracalary membrane detachment, and the routine management is possible in these cases, ignoring the coloboma, because the cause of detachment is unconnected with the coloboma itself. But you must be sure that there is no ICM detachment. If you are not sure, you better assume that the coloboma could be contributing potentially and manage appropriately. What to do in that situation we'll come to later. If you have only an intracalary membrane break, which is often seen in the fellow eye when they come with loss of vision in one eye, what you find is only a intracalary membrane detachment. It doesn't spill over to the normal retina, and hence the visual acuity is still not affected. Now these are the eyes which are potentially at risk for spilling over and causing loss of vision, and hence are good indication for prophylactic retinopexy along the border of the coloboma, very strongly recommended. But if you have a break at the locus minoris resistentiae alone, it is something which is probably not possible, because you require pull on the normal retina or the ICM for the break between the two to occur. But what you very often see is a break at the locus manalis resistentiae with a break in the ICM with or without a peripheral retinal break. This is the most common way of presentation to the clinician. Then you find a retinal detachment in the normal retina along with an ICM detachment which is variable in extent, and the break in the ICM is not always discernible clinically, and a peripheral break may be present, may not be present, means it may not be contributing. So if there is no peripheral break, then there has got to be an ICM break for the liquid vitreous to go into subretinal space through the break in the ICM. If there is a peripheral break, there need not be an ICM break, because the liquid vitreous can go from the peripheral break into subretinal space. So you need some entry for the liquid vitreous to go into subretinal space first. So whether it is starting from the subretinal space and then lifting up the ICM because there is a communication established between the two, or it is starting from the ICM detachment and spreading upwards into normal retina, is something which can happen in a given eye in any particular way. So when we manage these cases, the variables we face with are the size of the eyeball, lens opacity, coloboma of iris, disc involvement, macular involvement, PVR. I may not be able to cover everything in 10 minutes time, but I'll quickly go over what we can. So in retinal detachment, traction caused by the ICM on the margin of coloboma could be also a potential problem. It can keep the edge lifted up, and hence your laser that you do, or 1 or 2 rows, may not be able to anchor the retina along the margin, and it can actually get lifted up despite it looking good on the table. And a chronic detachment along the border of coloboma may be there to start with, so that the retina around the coloboma margin has been contracted because it's been detached for a very long time, along with gliosis. But very often you can see a pigmented degeneration there as well, and then it can spread more rapidly once enough vitreous is liquefied to generate subretinal fluid. So how do we identify the site of communication between subretinal space and sub-ICM space? In this picture you can see this is attached retina, this is detached retina, this is the border of detached retina, and this is the area of ICM detachment you can see, and this is the coloboma. And when we did OCT at this point, you can see the gap in the subretinal space and the sub-ICM space showing a clear communication. That means this is the break at the site of least resistance. While a little beyond, when we did the OCT, there was a point is not showing there. Oh, okay. So if we see the subretinal space and sub-ICM space is communicating here due to a break in the locus manalis resistentiae, while at this point there is no break. So it can be very focal communication. And if we have an advanced notice of exactly where the focal communication is, we can target that area for laser treatment more precisely. But there is a caveat to this. When we manage the case during vitrectomy, we induce posterior vitreous detachment, and that can be a very violent process in these eyes. And because of the violent process, we actually induce more communications between subretinal and sub-ICM space, which probably were not there to start with. So it makes sense to treat the entire coloboma margin when you are inside the eye, rather than think that this area alone is having a communication. But of course, there are selected cases like the case which you saw there, where the detachment is only restricted to 1/2 of the retina. The rest of the coloboma margin theoretically can be left untreated. But when you are in, again, you tend to play safe and you treat. So once we operate, we go routine management, careful evaluation of the coloboma margin, need to exclude ICM detachment, as I told you, if need be with OCTs. I'm talking about only peripheral retinal detachment with no ICM detachment, where I know the cause of detachment is unconnected with the coloboma. But you're inside the eye with vitrectomy, you examine the coloboma margin very carefully to make sure there is no ICM detachment, and then you manage appropriately. Sclerotomies have got to be more anteriorly placed than usual because they're microphthalmic eyes, so corresponding to the microphthalmia, you may have to shift them more and more anteriorly. And lens need not be saved in very extreme microphthalmic eyes, because then you're trying to compromise a lot on the amount of vitrectomy you do. So very extreme microphthalmic eyes, I tend to remove the lens. There's a questionable role of encerclage, because large colobomata with entire inferior 4 clock hours or more affected by the coloboma, the inferior 4 clock hours don't need any support in the periphery. The remaining 8 clock hours can perfectly be tamponaded by internal tamponading agent. So you really don't require an encerclage in most cases, provided you do a good thorough vitrectomy. Selected cases I add encerclage as well. A debulking of the vitreous base is important with the indentation. Induction of PVD is most vital because most cases of failure are because you have not induced the PVD properly. And inducing a PVD, as I said, is not easy. You can start at the ICM and come towards the retina, or other way around, using triamcinolone alone and using a forceps to peel the vitreous collagen from the disc sometimes helps. Means you peel a few collagen fibers and then use suction, it lifts up much more easily than keeping on using heavy suction in a detached retina, where you always run the risk of sucking the retina as well. And because of this violent detachment of vitreous, the locus manis restringia can break at multiple locations. Once you do fluid air exchange following vitrectomy, and don't suck the fluid to subretinal space just to see the behavior of the retina, you just suck directly over the optic disc or at the coloboma floor, and you see what happens. If the retina becomes bullous and gets pushed towards the coloboma margin, but doesn't spill over into the coloboma, but it remains bullous, doesn't get flattened out, it tells you what? It tells you that the fluid is able to push up to the coloboma margin, is not able to get into the ICM, sub-ICM space, and is not able to come into the vitreous cavity. Perhaps there is no communication between the subretinal space and sub-ICM space, or the communication is very small, so it's not able to push through a thick fluid, and it's not able to come into vitreous cavity because ICM break probably is not there. But suppose it balloons, but there's a spillover of the detachment within the coloboma, then you know the ICM also is detached, but it is still not flattening, so ICM break is not probably there. While if it flattens totally, then you know that all three are there, right? This fluid is able to be pushed into sub-ICM space and on into the vitreous cavity. That tells you how the retina is behaving and also tells you how much to treat. Then we do endolaser around the breaks and around the coloboma margin, about 2 to 3 rows. Diode laser is preferred because you don't want to damage the nerve fiber layer, especially where the coloboma involves the optic disc. If macula is just skirting the coloboma, very often putting 2 rows can actually destroy the macula permanently. So those cases, you go as close to the macula as possible, fovea as possible, and leave the just subfoveal area without treatment, taking a risk. You are hoping that at that point there is no communication between subretinal and sub-ICM space. And if that patient develops perhaps a recurrence when you remove the oil, then you have no choice except to destroy the macula. It's important to treat right up to the ora, means you go along the coloboma margin, and where it hits the ora, you go along the ora as well, because these are eyes which are microphthalmic. The ora is closer to the limbus than in normal eyes. So however anterior you make sclerotomy, there's always a risk the vitreous pull can actually pull on the retina and can cause peripheral dialysis, and hence you need to treat the entire ora. Internal tamponade is preferred with silicone oil. Can I go ahead with half a minute more? Yeah. Gas may be okay in selected cases where only small sector is to be tamponaded. This is just our experience, was published in 1998 of 85 eyes. We have had success of 81.2%, with nearly 70% having better than 10/200 vision. It was upgraded in 2006, the unpublished data, which was presented in Academy by my colleague Dr. Muna. And of 126 eyes, there the success rate was even better because we learned from our mistakes. One, having a good thorough vitrectomy, 100% induction of PVD in all cases, and detaching the vitreous as far into the periphery as possible, and debulking the peripheral vitreous nicely, and treating all the way along the ora, because the initial mistakes we did, especially when we were using Markhammer's lens or not a wide angle lens, was leaving behind too much peripheral vitreous and having a peripheral dialysis which is undetected. And when you remove the oil, you find that dialysis is causing the detachment again. So now that is not a problem with a wide angle lens, good thorough vitrectomy, and treating the entire peripheral ora, the risk of recurrence has been minimized or reduced significantly. Thank you very much for your attention.